Testing, testing. Testing.
Good morning, everyone. All right, we're going to start this. I'm so glad everybody's here. I wanted to introduce myself to you. Many of you know me, Pat Tulungan, and I'm the co-founder of the Children's Neuroblastoma Cancer Foundation. We started the foundation in 2000. I lost my son, Nick, to neuroblastoma back in 1999, and stage 4. Went through treatment for the 4 years, but unfortunately, he didn't make it. But what it was a true inspiration to me, because we didn't have a whole lot of information available to us, because I'm old and this is pre-internet. So I had one piece of paper that gave me information about neuroblastoma. And so that really bothered me, that there just was not enough information. And so that became, one of the main premises of starting CNCF, was to provide the families, with the necessary resources and information that they need, to make informed choices, because everything is different, everything is evolving, and, everything has to change. And so we're hoping what this conference does, for you is to provide, the resources and everything so you can make these decisions. And again, this was back in 1995, and so much has changed, since then. So what we hope is, again, you walk away, from this conference with some knowledge maybe you didn't have before, or maybe you're hearing a word, you heard it before, but you didn't really know what it is, and now you know what it is. So again, everything is an evolving process, and so it's important for us to continue to keep having these conferences. We encourage you to please keep coming back, again, because everybody's situation, could change today, could change tomorrow. We do try to take care of all aspects of neuroblastoma if we can, because so many families are brand new families. There are families here whose children have relapsed or have refractory disease. We have parents who have lost their children, and we have long-term survivors. So our goal is to make sure that, we have a program available for everybody. Sometimes it works and sometimes it doesn't. We do our best to make sure that, we address as many issues as possible. So that's who we are, that's what we've done, that's the premise of these conferences. We've awarded almost $3 million in research at hospitals across the country. So, we do CHOP, we do Sloan, we do CHLA, NANT, so we do try to determine, we have a medical advisory board that reviews our grant applications. And so, again, try to, fund as much research as we possibly can in various areas. I don't know if all of you have seen, but we have a parent handbook online that, again, is constantly changing and evolving. So that's another thing that we hope you find, valuable. We, again, trying to update it as much as we can. We have a medical advisory board, Dr. Daryl Yamashiro from Columbia, Dr. Chung from Sloan, Dr. Patrick Reynolds from Texas Tech, Dr. Bagatelle from CHOP, Dr. Julie Park at St. Jude now, and Sue Cohn and John Maris are our consultants. So the way we work this conference is each doctor will give a 30-minute presentation, and we'll have a 15 to 20-minute question and answer session after each presentation. We do ask that, I know it's hard, But we do ask, if you're going to ask questions, that you do them as general as possible and not make it about your child and specific things, just so that we can, again, get a very broad spectrum of questions and some good answers for you. So if you could keep that in mind. We have 2 microphones set up, one over there, one over there. So, and we are live streaming it. So, and what we would like is to come up, ask your questions, and make sure that, we do talk to each other. And I know people are going to start talking amongst each other, but if we could keep it at the microphones, that would be good, because we want to make sure the people who are watching get the full value, of what's being said here. Let's see, to have that. And 2, if you have any questions, or if you're afraid to stand up and talk, write them down, and we'll go ahead and present it to the speaker either now or afterwards. Okay, this conference too it's meant for education, and I know you're going to want to talk to all the doctors and everything. We do ask, though, that this not be like a session where you're getting like a second opinion. Again, I hate to say, speak in generalities if you can, and if you do want a second opinion, please ask for the information as to how you get, a second opinion for your child. We have a kids room, so for those of you who brought your children, they should have a good time in there. I saw painting. We do have a balloon maker who's fantastic. We have a face painter who's really good. They will be here in the afternoon with the kids, having a good time. So there's plenty of arts and crafts. They have movies. They have Xbox. Is that the current one? I don't know. I'm not into that. Nintendo Switch and all that. So the other thing is we'll have lunch together. So at lunchtime you can go grab your kids and then bring them back into this room over here. But when we have a break, you will not be bringing your kids, because it's only a very short 15-minute break. The other thing is because when they see you, they're not going to want to let you go. So if you can, avoid it, great. If you can't, let us know, and you can talk with Sherry and her daughter Cassie in the kids' room. Let's see. If anybody's sick, the kids are sick, again, we ask you not to have them in the kids' room. Friday night, tonight, I think it's 6 or 6:30. We have a really nice dinner. We have a DJ coming. I anticipate everyone will be up on the dance floor dancing. I don't want to see anybody in a chair. You're all going to get up. We're going to do a conga line like we always do. So start getting your muscles all loose and everything. So, and I wanted to thank my assistant, Nikki DiBenedetto. I don't know if she's here or not. For making all the travel arrangements for the families who needed them, for updating our Facebook, our website, anything and everything. She coordinates and helps out that way. She's, a wonderful person to have with us. I wanted to thank Sherry and Cassie for running the kids' room for us. Again, Mike Mothy, our balloon maker, will be here with his wife. They donate their time. They're wonderful people. Have Hannah. People were here last year. Our DJ is Hannah. She will be here again. I have Mike Elbaum helping us with the video. We have Elvaro, who's helping us with the video and live streaming, so I want to thank them for their assistance here. And I do want to acknowledge our supporters for this conference, because without them, this conference, we wouldn't be able to have it. It's just, it's a very costly event, but what our goal is to make sure that none of you have to put out hundreds and hundreds and hundreds of dollars, because everybody needs an equal opportunity to learn. So if you have the money, great, you can pay, but if you don't, we want to make sure that you have the capability and the ability to be here. So we do subsidize the hotel rooms. Almost all your meals are free. So I just wanted to thank the wonderful people who have supported it, and that's YMABS Therapeutics, Jubilant Radio Pharma, U.S. World Meds, the Thank Foundation, Dr. Chung and his wife Irene, the Frock Foundation, the Friends of Catherine, A.J. Nafso family, and the Fagan Family Foundation, and the Nick Foundation of Northwest Indiana. And like I said, this just is extremely, costly for us, but I wouldn't have it any other way. I mean, to see all your faces and to you people making, lifelong friendships, because as we talked, you can't always talk to your friend, your neighbor, because they don't get it. So to be able to look in each other's eyes and know exactly what's going on, to me is priceless, and we continue to keep having these as long as we possibly can. So that's it for my part of it. And we're going to go ahead and begin our introduction. Ami, what did I do with your sheet? Here it is. It's like I'm trying to add stuff to it here. Our first presenter is Dr. Ami Desi. She's an attending physician at Comer Children's Hospital at the University of Chicago. She's an associate professor at the University of Chicago, Comer Children's. She received her MD at Robert Wood Johnson Medical School and completed her residency at Yale New Haven Hospital and her fellowship at Children's Hospital Philadelphia. Her area of expertise is neuroblastoma and other solid tumor cancers, as well as developmental therapeutics and adolescent and young adult cancer care. She is a member of numerous associations, and she's a program leader for solid tumor and an active member of COG in the neuroblastoma community. She will be talking today on neuroblastoma basics. Dr. Ami Desi.
All right, good morning, everyone. It is a pleasure to be here today and see some familiar faces and old colleagues, people who trained me along the way, and other friends as well, too. So today, my talk is going to be neuroblastoma basics, and I hope this sets the foundation for the other talks that you'll hear during the course of these 2 days. These are my disclosures. All right, so as all of you know in this room, neuroblastoma is the most common solid extracranial malignancy in children, so outside of the brain. It originates from neural crest tissue, and most commonly in the adrenal glands, or the organs that sit right above the kidneys, as well as the sympathetic ganglia, so it could present as a mass anywhere from the neck into the pelvis. And it is classified as a small round blue cell tumor based on the way it looks under the microscope. There are about 750 to 800 new cases per year in the US, and it makes up about 7% of all childhood cancers. And of all the patients diagnosed in the US, about half of these children will have high-risk disease. And we know that there is a higher prevalence of high-risk disease in Blacks and Native Americans. And if you look at this plot on the right, in the red are the incidence of patients with neuroblastoma by age. And as you can see, it's really a malignancy of infancy and younger childhood. And as you get into older childhood and adolescence, the incidence of this really drops. Neuroblastoma is very much known for its broad spectrum of clinical behavior, which is really reflective of the biology of the tumor, where there are certain tumors that may spontaneously regress on their own, or patients who may just need surgery as part of their therapy. Others will need chemotherapy or really intensive multimodality therapy, including chemotherapy, surgery, transplant, and immunotherapy. So there's really no consistent environmental factor identified in the etiology of neuroblastoma, and this is just a question we get a lot from families when they're first diagnosed. There is a small percentage of patients who may have a family history or presentation that may be consistent with having a germline mutation leading to neuroblastoma, and Dr. Sokol will go over this in more detail in her talk. There are certain syndromes that may predispose one to develop neuroblastoma, such as Costello syndrome, Noonan syndrome, Beckwith-Wiedemann syndrome, and Li-Fraumeni syndrome. And another question comes up, especially based on all the screening that we do in the adult population. Is there a role for screening in the general population? So in the past, there were population-based studies completed where urine catecholamines, urine HVA, VMA were measured in infants less than a year of age in Japan, Canada, and Germany. And in these studies, they saw that there were increased rates of diagnosis, but these are really early-stage tumors that were mostly those of favorable biology and may have regressed on their own. And identifying these patients actually did not decrease mortality. So the conclusion really was that tumors diagnosed in infants by mass screening are unlikely to progress to life-threatening advanced stage disease, and many are likely to spontaneously regress. So more patients were being identified, but however, with interventions, there may actually be more morbidity than help for these children. As for the clinical presentation, it can present as, neuroblastoma can present as an asymptomatic mass, again, anywhere from the neck into the pelvis, given the location of the sympathetic chain. Horner syndrome, or if you have compression of the stellate ganglion or one of the sympathetic ganglia. Spinal cord compression, as it can be paraspinal and encroach into the spinal space. Big liver or hepatomegaly, pallor, skin lesions. Or you could have systemic symptoms such as weight loss, irritability, fever, hypertension. This we tend to see more with disseminated disease or stage 4 disease. Patients may present with VIP syndrome or this intractable diarrhea on rare occurrences, and may also present with opsoclonus myoclonus syndrome or dancing eyes, dancing feet. And this is usually associated with more favorable type tumors, the opsoclonus myoclonus. As for, we can also see bone pain or patients with a limp or refusal to walk, and again, this is often seen in patients with disseminated disease, and patients can also present with raccoon eyes. I just briefly wanted to touch on the adolescent young adult population. I mentioned that neuroblastoma tends to happen in younger children, and it's really a very different type of disease in older patients, and it's rare for it to occur in this population as well. And they tend to have more of an indolent disease course and may not be as responsive to some of our conventional therapies. And they do tend to have inferior outcomes compared to younger patients. And they do tend to have a unique tumor biology. Their tumors may have segmental chromosomal aberrations or ATRX mutations. And there is a need for novel therapies for this group of patients. So as for evaluations and tests, of course, we start with a full history and physical exam. We will start by drawing blood counts or a CBC to see if any transfusions are needed or if any blood counts are low that might indicate marrow disease, blood chemistries, LDH ferritin, urine catecholamine metabolites, HVA and VMA. And we will then proceed with tumor imaging as well, and this can include a CAT scan or MRI. And we will also, if we are suspicious of neuroblastoma, have patients undergo an MIBG scan, which I'll talk about a bit more in the next few slides, versus a PET scan. About 90% of neuroblastomas are MIBG avid at diagnosis. And then, of course, to confirm the diagnosis, we will proceed with a biopsy to look at the tissue under the microscope and also look in the bone marrows to assess for disease in that location. So neuroblastoma is diagnosed by unequivocal pathologic examination of tumor tissue, again by a biopsy, or unequivocal tumor cells in the bone marrow combined with a detection of elevated urinary catecholamines, and that may happen in patients who might not be able to undergo a tissue diagnosis or biopsy of their tumor. So I mentioned MIBG scans, which I'm sure everyone in this room is familiar with, but MIBG is an analog of norepinephrine and is labeled with radioactive iodine and taken up by neuroblastoma cells. And essentially, the tracer is attached to a small amount of radioactive iodine that makes the neuroblastoma light up on the scans. And then we try to quantify how much disease is there by something called a Curie score, which I'll go into in the next slide. And to note, there is normal uptake in the salivary glands, bladder, and liver, so we are aware of that. And we'll prescribe our patients thyroid protection with SSKI drops or Lugol's, as you may have heard, with the potassium iodine helping to protect the thyroid from the MIBG uptake. So this is someone we fondly call Curie Man. And as you can see, he's broken up into multiple sections. And based on this, we come up with a bone score and a soft tissue score. And that helps us quantify how much disease may be present at diagnosis and then present along the way as patients go through therapy. So as for neuroblastoma prognostic markers, there have been many markers that have been investigated over the years, and 5 important markers that really help us risk stratify our patients are the stage of disease, age of the patient, McN status, ploidy of the tumor, and histology, or how it looks under the microscope. And then more recently, other things are being added to help further risk classify patients, and this includes things such as segmental chromosomal aberrations. So again, this is just to focus on the 5 major prognostic factors, again being age, stage, MICN status of the tumor, histology, and tumor cell ploidy, with age being broken up at about 18 months. Stage of the tumor, we used to use the International Neuroblastoma staging system, where we stage things 1 to 4S, and now there's a newer staging system that I'll go into, which is the INRG staging system, L1, L2, M, and MS. Whether the tumor is MICN amplified or non-amplified, whether there's favorable or unfavorable histology under the microscope, and how much DNA content is within the tumor as well. And putting all of these 5 things together helps us, you can see this chart, risk stratify our patients. And I just wanted to focus on one thing. For patients who are greater than or equal to 18 months of age, who do have stage 4 disease, these patients are automatically high risk despite other markers of their tumor biology. And I briefly wanted to touch on the INRG task force, and Dr. Applebaum will go through the INRG database as part of his talk. But the International Neuroblastoma Risk Group Task Force convened in 2005, and it was really put together to help address the problem of non-uniformly defined risk groups in neuroblastomas. You know, in the US and in Europe, we tend to risk stratify patients a little bit differently. And they also helped develop a pre-treatment staging system, the INRG staging system that I will go into. And this now includes image-defined risk factors, or the identification of tumor wrapping around important blood vessels or critical structures that may make it more difficult for a surgeon to take out the tumor or may represent a more biologically aggressive tumor. And this is not dependent on the degree of surgical resection like the previous classification system. So there was a proposed new risk classification system that came out of this task force, and this was derived from 8,800 patients diagnosed between 1990 and 2002 across the world. And out of a bunch of statistical analyses and regression analyses, they saw that prognostic factors within this cohort included INRG stage, age, histologic category, grade of differentiation, MICN status, 11q aberration, and tumor cell ploidy. So to touch briefly on the International Neuroblastoma Risk Group staging system, again, this is a pre-treatment staging system and based on image-defined risk factors. So now, simply put, L1 tumors are localized tumors without these image-defined risk factors. L2 tumors are local regional tumors with 1 or more image-defined risk factors. Stage M represent distant metastatic disease, except the MS group, which again are a unique group of patients less than 18 months of age that may have lower stage tumors with metastatic disease confined to the skin, liver, or bone marrow within 10%. And I'm not going to go through all of these, but these are some examples of image-defined risk factors. So again, tumors wrapping around really important blood vessels or really very close to important structures within the body. And this slide just shows some of the differences between the 2 staging systems. So stage 1, 2A, 2B, and 3 tumors are now grouped into this L1 and L2 group. Stage M is the same as the previous stage 4, and MS overall is the same as 4S, except with a little bit of change to the definition, including children under 18 months of age. And here is the proposed international risk group classification schema that we're not technically using at this time, but is a way to propose doing global studies for patients with neuroblastoma and having everyone uniformly risk stratified. I'm going to end this section on risk stratification by just touching on our newer COG risk classification system. So given the new staging system, there are a few plots that I'm going to show that starts with what type of tumor. So having an L1 tumor, and then defining the risk group based on age, tumor size, extent of surgical resection, MICN status, helps us stratify patients into low or high risk in this group. And then again, for L2 tumors, we take into account MICN status, age, histology, ploidy, and segmental chromosomal aberrations, which is the newer thing compared to the prior staging system. For stage M, age, MICN status, histology, ploidy, and segmental chromosomal aberrations. And for MS tumors, age, MICN status, symptoms, histology, ploidy, and segmental chromosomal aberrations. And again, this helps us risk stratify our patients and will be used in future studies. So what is our current approach to treating neuroblastoma? And in this section of the talk, I'm going to talk about why we do what we do, how we got to certain treatments that we are administering to our patients, and a little bit of a basics on clinical trials. So our current treatment approach is to tailor treatment according to predicted behavior based on clinical characteristics and tumor biology. And you can see that a lot based on how we risk stratify our patients. And it is not possible to learn what treatment is best if each patient is treated differently. And there are circumstances where we think we may have to take someone off a clinical trial, or maybe they aren't the right patient for a clinical trial, and maybe we have to treat them in a different way based on what their response is. So of course there are those scenarios. A series of clinical trials for children with low, intermediate, and high-risk neuroblastoma have been ongoing for decades to identify treatment strategies with optimal survival rates with minimal toxicity, with the hope of minimal toxicity. So what are clinical trials? They are studies involving people that can make progress in preventing, diagnosing, and treating cancer. And each clinical trial follows a set of rules called a protocol that describes who can participate in the study and how the treatment will be given and monitored. And there's a lot of statistics involved in making sure that the patient safety is taken into account as the protocol moves forward, and to see what we call monitoring rules. If behind the scenes is someone doing better, or one group of patients doing better than another, does this study need to end sooner than its actual timeline? And then governmental and non-governmental organizations may sponsor clinical trials. And clinical trials remain the most reliable and only accepted scientific method to find out if a new treatment works better than the current standard of care. So it's important to learn as much as possible about a clinical trial before participating, and talking with your doctor and the research team can help you understand what to expect from a clinical trial. And I've definitely encountered different conversations with families, and some are very interested and want exposure to a new agent that may potentially improve outcomes, and other families feel much more comfortable sticking with standard of care. And so it's definitely an informed but personal choice that each family makes. So certain questions that come up that are important to ask your provider: what clinical trials are appropriate for me? What is the purpose of this clinical trial? Why does the research team think this treatment, drug, or medical device will work? Why is this specific approach being studied? What are other treatment options that are available to me, including other clinical trials or standard of care or other options? And who or what organization is sponsoring the clinical trial? So who can participate on trial is determined by inclusion and exclusion criteria. These criteria are based on a person's age, type of disease, medical history, and current health. Inclusion criteria may help make sure that all patients in the clinical trial are medically similar. For example, all patients having high-risk neuroblastoma on a specific study. And if people have too many medical differences, it's difficult to interpret the results. And exclusion criteria help keep people safe. And this is just a brief overview of clinical trial phases. So clinical trials are made up of distinct parts called phases. And a phase 1 study is where clinical trials are used to show that a new treatment is safe for a small group of people and find the dose of the drug. A phase 2 trial is now you have the dose and you want to investigate it in a specific population to see how well it works or how responsive the tumor is to the treatment. And phase 3 clinical trials compare the new treatment with the standard treatment in a large group of people. So these phase 3 trials is really what we talk about in the frontline setting. So phase 3 clinical trials, the goal of these trials is to take new treatment that has shown promising results when used for a small group of patients, for example, in a phase 2 study, and compare it with the current standard of care for the specific disease. In this phase, data are gathered from large numbers of patients to find out whether the new treatment is more effective and possibly has fewer side effects than current standard treatment. Phase 3 trials are usually randomized, meaning the patients receive either the investigational treatment or the standard treatment in a non-ordered way. That is, for the most part. There are times where certain phase 3 trials are not randomized. All right, so that's just a little bit of a primer on clinical trials, and I just wanted to highlight a few trials in the low, intermediate, and high-risk groups that have informed how we treat patients currently. So the first study is P9641, which for the low-risk population, the question was to demonstrate, or the objective was to demonstrate that surgery alone would achieve 3-year overall survival, or greater than 95%, for patients with asymptomatic INSS stage 2A or B neuroblastoma. And in this study, they had patients who were asymptomatic receive surgery alone and not chemotherapy immediately and get the best maximal surgery. And then symptomatic patients got anywhere from 2 to 4 cycles of chemotherapy plus surgery. And what they saw was through this approach, excellent outcomes were obtained. And when they compared the patients who got surgery alone to those with chemo plus surgery, the outcomes were very similar. So in general, for low-risk patients, we tend to use surgical resection as our primary modality of therapy. Chemotherapy may be used in certain situations, and there are small cohorts of patients that can be observed as well. Moving on to intermediate risk neuroblastoma, I was just going to highlight 2 trials here. One is A3961, which the objective of this study was to determine whether a 3-year estimated overall survival of more than 90% could be maintained with reductions in the duration of therapy and drug doses using a tumor biology-based therapy assignment. And you could see the trend for low and intermediate risk neuroblastoma. Many of these trials where these patients are doing quite well, and how could we further reduce therapy in some groups of patients while maintaining good outcomes? So that's really the goal of these non-high-risk studies. And here, patients with favorable biology tumors had 4 cycles of chemotherapy plus surgery, and those with unfavorable biology had 8 cycles of chemotherapy plus surgery. And again, excellent outcomes were maintained with this approach. And what the study showed was that for intermediate risk therapy, you can reduce therapy while maintaining excellent outcomes. For ANBL 0531, this was a response and biology-based therapy for intermediate risk neuroblastoma. So using an algorithm, could we further reduce therapy in patients based on biology and clinical factors. And here they also used 1p11q allele status to establish what group patients fell into and how much therapy they would receive. And response and the endpoint of the study was based on achieving a partial response for those with local regional tumors, and those with disseminated disease, I believe, had to reach a VGPR. And here, patients received anywhere from 2 to 8 cycles of chemotherapy plus or minus surgery. And again, excellent outcomes were maintained with this algorithm. And our current standard for patients with intermediate risk neuroblastoma is to give 2 to 8 cycles of chemotherapy depending on response, and plus or minus surgery. And the most recent COG non-high-risk study is ANBL 1232, and this study just recently closed to accrual. But the objectives of this study were, again, to further decrease therapy for certain subgroups of patients, one being infants less than 12 months of age with small INRGL1 tumors, and those who were less than 18 months of age with localized neuroblastoma unfavorable biology, and whether some of these groups could receive observation alone as part of their frontline therapy. And finally, for patients with INRG MS disease, to achieve at least or greater than an 81% overall survival for these infants who have symptoms and otherwise may have done unwell on prior studies, and to initiate treatment early for these patients. And then to quickly summarize some of the landmark studies in high-risk neuroblastoma, one was CCG 3891, which compared proceeding with myeloablative chemotherapy and autologous stem cell transplant versus continued chemotherapy after undergoing induction therapy for high-risk neuroblastoma. And here, the study led by Dr. Mathey showed that myeloablative chemotherapy plus autologous stem cell transplant improved event-free survival for patients. And then the study conducted by Dr. Alice Yu and others, ANBL 0032, then asked if including targeted immunotherapy or an anti-GD2 antibody plus isotretinoin improved outcomes for patients with high-risk neuroblastoma in the post-consolidation setting compared to isotretinoin alone. And here in this study, we saw that event-free survival and overall survivals improved with immunotherapy plus isotretinoin following autologous stem cell transplant. And finally, ANBL 0532 investigated single versus tandem autologous stem cell transplant. And in this study by Dr. Park, they showed that tandem autologous stem cell transplant improved event-free survival for patients with high-risk neuroblastoma, especially when followed by immunotherapy in a post-hoc analysis. So this leads us to our current COG standard of care for high-risk neuroblastoma, which again includes 5 cycles of induction chemotherapy, surgery, tandem autologous stem cell transplant, and radiation as part of consolidation, and then immunotherapy in the post-consolidation setting. And through many of these trials and and advances in treatment, there has been a successive increase in overall survival for COG patients, as seen here, from 1990 to 2015. But as you can also see, there's a lot of room for further improvement, and that is really the focus of trials and investigations moving forward. And as many of you know, this is our current phase 3 study within the COG, ANBL 1531, which is meeting its accrual. Will probably meet its accrual very shortly. But in this study, patients are, the study arm is investigating the introduction of I-131 MIBG therapy into induction for patients with high-risk neuroblastoma and comparing that to standard of care. And then for patients who do have tumors with an ALK aberration, adding an ALK inhibitor early on and throughout therapy. So next, I'm just going to highlight a few targeted therapies that are present for our patients with high-risk neuroblastoma, and you'll hear more about this throughout the course of the next 2 days as well. So 3 really important modalities of treatment for neuroblastoma are anti-GD2 antibodies, I-131 MIBG therapy or radiopharmaceutical, and ALK inhibitors for patients with tumors that have an ALK aberration. And anti-GD2 antibodies are antibodies that target GD2, which is uniformly expressed on neuroblastoma. And there's multiple types of anti-GD2 antibodies, dinutuximab beta, which is used primarily in Europe, and naxitamab. And the side effect profile really tends to be allergic type reactions, as well as pain, and that's because GD2 is also expressed on the long nerves. And that's why pain management is a big part of our supportive care when administering these antibodies. And we've made great successes in the relapse setting by also combining anti-GD2 antibodies with chemotherapy. So MIBG therapy is really a similar concept to the scan, but with a higher radiation dose. So the MIBG tracer is taken up by the neuroblastoma cells. It's attached to radioactive iodine, again at a higher dose, and essentially is providing localized radiation to patients. This requires either a lead room or shields to protect family and staff from radiation exposure. Generally requires stem cell rescue to help counts come back faster. And as I mentioned, is being studied as part of frontline therapy for high-risk neuroblastoma in the current phase 3 study. And here, and I'm sorry, the images did not come out as well, but you could see in the baseline images, here's a patient with multiple bony lesions or really avid MIBG scan with disseminated disease. During admission, this gets actually a little bit brighter, and this sometimes frightens families. We get an MIBG scan right after MIBG therapy to really show that the MIBG uptake has occurred. So we don't really use this for response, but we do want to make sure we get this scan. But then 6 to 8 weeks later, we then assess response, and you could see this patient's bone disease very nicely cleared by MIBG therapy. And this is just an example of another patient with MIBG avid disease. And then this is their scan 7 weeks after therapy. So ALK, so about 10 to 15% of children with high-risk neuroblastoma have a tumor with an ALK aberration, and often this is a mutation or an amplification. And crizotinib is a small molecule inhibitor of ALK, MET, and ROS1, and was one of the first ALK inhibitors to be investigated in neuroblastoma, and was part of the initial ALK arm of ANBL 1531. Now we're have included lorlatinib, which is a next-generation ALK inhibitor, which is part of the phase 3 study. So we talked a lot about treatment, but with treatment, unfortunately, comes some late effects as well, too. And this goes back to our goal of we really want to optimize outcomes for our patients and find a way to minimize some of the late effects. And I believe you'll be hearing other additional talks regarding late effects during these 2 days, including that regarding fertility. So patients are getting chemotherapy, radiation. This may impact their heart, endocrine system, hearing, may lead to second malignancies, may impact neurocognitive outcomes, and there's a lot of surveillance again for any pulmonary toxicity, renal toxicity as well. So again, this is really the focus of every time we develop a new treatment strategy, how can we optimize outcomes and minimize toxicity? So there's a study being run through the Children's Oncology Group called the LEARN study that's being run by Dr. Tara Henderson and Dr. Lisa Diller. And this is really to understand what are the late effects of our current era treatment strategies for high-risk neuroblastoma. And their overall goal is to evaluate the prevalence of adverse events in high-risk patients treated after January 2000 and determine the impact of these events on health-related quality of life. And these are patients who are enrolled on the biology study and greater than or equal to 5 years from diagnosis. And they're collecting treatment exposure data through detailed abstraction of medical records, and then evaluating outcomes through surveys and full-day clinical evaluations. So hopefully that will provide some insight as to what our treatments are doing and how can we do better. So again, how can we continue to improve outcomes for our patients? And this is really through investigating novel therapies, through basic translational research and clinical trials and other clinical research, and to further refine risk stratification and provide more precise treatments to our patients. And many investigators, many that are speaking today, are looking at biomarkers of therapy response and resistance as well, and other ways to identify response and disease. And of course, collaboration, all of us working together to make sure we do what's best for our patients. So I just wanted to thank you guys for your attention. And I really wanted to give a big thank you to Pat and all the organizers for the conference and all the work they put into trying to inform the general community about neuroblastoma. Thank you. I don't know if there's time for questions, Pat. I probably went over a little.
Hi, Dr. Desai. Thank you for the talk, and just a personal thank you to you. You and the team at Comer have been taking care of my son James since he was diagnosed in November and giving him some of the best care we could have ever hoped for. So just a personal thank you to you and the rest of the team at Comer, and thank you for the talk. I'm just curious, can you tell us a little bit about what gets you the most excited when you think about some of the next generation therapies and where you're hoping that we might get in the next 5 and 10 years?
Yeah, that's a really great question. You always ask the best questions. So first of all, thank you. We appreciate it. And, of course, as you know, it's a team effort to care for our patients from both the family side and the provider side. And it's been a pleasure to be part of that. What gets us most excited? I think immunotherapy is really still exciting. And I think we're looking at different ways to integrate immunotherapy in the frontline setting. And Dr. Federico may go into this in a bit more detail today as well, too. Cellular therapies, other novel types of immunotherapies, or even beyond that, other ways of delivering drugs. How can we be better? In the recent past years, we've seen patients with, relapses, and how can we be better at really trying to target certain areas of the body that we're not so great at getting, drug into as well. But I would say a lot of the work that's being done in the lab to look at different types of immunotherapies, personally for me, is exciting, but there's much more even beyond that.
Good morning.
Good morning.
Kimberly Turner from Columbus, Georgia. My question is, you said the catecholamines in the urine, detection it early really didn't help the outcome, but doesn't it help a little when you're trying to detect if it's going to grow or not? Because a lot of the kids are not detected until later on, but they start having small symptoms, maybe like my daughter started to wet the bed, and that was a signal because of the tumor was blocking her bladder and bowels, and a simple urine test could have said, hey, your kid may have cancer, let's check it out more before the tumor got bigger and spread it to other parts.
Yeah, thank you for the question. I think urine catecholamines are tough, and they're not elevated for every patient at diagnosis. They're helpful when they're elevated to be able to track it over time, in general, for the way we monitor our patients. In the context of screening and that slide that I brought up, I think the point of that is the group of patients that they were screening were really the very young ones that had tumors that may have gone away on their own that we may have not even ever known about, but because they were identified, then interventions were made, and that actually caused more harm than good to certain children. So I think they were, in that population, identifying tumors where children would there wouldn't be a high rate of moving around to different parts of the body, that it would just stay localized or go away on its own. So that is really why the screening went away.
Okay, one more question?
Addressed a little bit later, but it's in regards to the MIBG added to the frontline therapy. You had mentioned that, at least on the slides, that it was effective at clearing bony disease. How effective is it against soft tissue disease?
Yeah, that's
compared
also
to
a really good question. In general, I think most of us think that MIBG works better for bony disease than soft tissue disease. And, you know, based on a patient's recurrence and recurrence pattern, we may decide what treatment might be best for a patient, whether they just have a little bit of soft tissue recurrence. Do we want to perhaps proceed with just some external beam radiation rather than MIBG? But could there potentially be micrometastatic disease floating around where MIBG might be helpful? So I think these are all the things that we think about. Or do we follow that external beam radiation with some systemic therapy as well to get rid of any micrometastatic disease? But in general, you know, I think it is a treatment that's known to be a little bit better for bony disease than soft tissue. But that doesn't mean that it does not work for soft tissue.
Okay. Is that it? Yeah, go ahead. Go ahead, one more.
Hi, Kim Travers from North Carolina. Question, my son is MIBG non-avid. Is it an option to get MIBG treatment?
That's a
even
real-
though
yeah.
they're non-avid?
And I'm sorry I didn't mention that earlier. One of the criteria to be able to get MIBG therapy is to have MIBG avid
Okay.
disease. Yes.
So it's not even an option?
No.
No?
Mm-mm.
Okay, thank you.
Yeah. Thank you.
Is that it?
Right. Thank you.
Okay. Thank you, Dr. Desai. I didn't plan this, but I'm sure everybody knows the famous Mexican